Good afternoon. Welcome back to UCSF Medicine Grand Rounds. Hope people had a nice holiday. I'm Bob Wachter. I'm chair of the UCSF Department of Medicine. Welcome to our live audience from the Department of Medicine and our other colleagues here at UCSF, as well as our friends at our partner sites in the UCSF Health Network. See, we all already have 400 or 500 people watching. As is our tradition, we will post this on YouTube tonight about 7:30. And our prior grand rounds have now received more than 300,000 views. A few quick ground rules for the audience are on here. You'll be on mute. If you have questions, please submit them through the Q&A button. My colleague Quinny Chang is monitoring those and will feed me the more interesting ones or ones we're not getting to. So let's go ahead and get started. Let me give you a little bit about the format today. We have basically 3 different segments. We'll begin with a George Rutherford update on the state of the pandemic with a focus on the current surges across the South and, of course, including California. That will go till about 12:25 or so. COVID has put every institution in our lives, from healthcare to business to the media to government, to the test. But it's hard to think of 2 sectors of our economy or 2 institutions that have been more challenged than our schools and our prisons. In both cases, the questions about what to do about them are leading the news, are incredibly important to all of us, and the solutions are anything but straightforward. I'm pleased today that we have experts from UCSF to help us make sense of what's going on in these 2 areas and walk us through the topics. The first segment that we will, the first group that we'll talk about will be what to do about the schools. I'll introduce our speakers now and then come back to them when it's time for that segment. The first speaker will be Naomi Bardach. Naomi is Associate Professor of Pediatrics and Health Policy in the Department of Pediatrics, as well as the Philip R. Lee Institute for Health Policy Studies. She's also Vice Chair for Health Services Research in the Department of Pediatrics. Her research focuses on improving the quality of care for kids. The next speaker in the schools segment will be Elizabeth Rogers. Liz is Associate Professor in the Department of Pediatrics. She co-directs our intensive care nursery follow-up program and specializes in neurodevelopmental and behavioral pediatrics for critically ill premature infants and other high-risk newborns in the ICU in the UCSF Benioff Children's Hospital. That segment will take us from about 12:30 till 1 o'clock, and then we'll switch to an equally important and challenging matter, and that is what to do about the prisons, with a special focus on the disaster happening just north of us at San Quentin Prison. Our speakers not only have deep expertise in healthcare and correctional institutions, but they were part of a team that was brought in to help advise San Quentin last month, advice that was not perfectly heeded. I'm sure we'll hear more about that during their segment. The 2 speakers for that segment will be Bree Williams. Bree is Professor of Medicine in our Division of Geriatrics. She directs UCSF's Criminal Justice and Health Program and a world-renowned program called Amend at UCSF, which focuses on changing correctional culture. Her work focuses on bringing the science of internal medicine, geriatrics, and palliative care to address health-oriented challenges in the criminal justice system. She'll be joined by David Sears. David is Assistant Professor of Medicine in our Division of Infectious Diseases. He directs healthcare quality for Amend, focusing on improving healthcare outcomes, safety, and patient satisfaction for residents of correctional facilities. That will take us to 1:30. I recognize it's a long segment and a lot of content, and I noodled a little bit over whether I should put off either the school segment or the prison segment till next week. But every time I thought about it, there was another news piece, or I heard from colleagues or friends that they were struggling with both of them. So it feels like they're so timely that it's worth focusing on them today. So that's what we will do. Thanks for joining us. Let's start off with George Rutherford. George, who by now needs no introduction, is a professor in our Department of Epidemiology and Biostatistics, medical director of Prevention and Prevention and Public Health Group. His research focuses on epidemiology and prevention of infectious and tropical diseases in public health, and he's become our and many other people's go-to expert to tell us about what's going on with the pandemic. So George, thanks so much.
Thanks very much, Bob. It's a pleasure to be with everyone again this afternoon. I wanted to run through kind of a current update fairly quickly, and then I'm happy to answer questions. First of all, I'd like to thank Dr. Wachter for allowing us pediatricians to speak at Medicine Grand Rounds. I'm sure will never be reciprocated. Well, maybe, we'll never know. So I think this is the most telling slide about how things have gone sideways in the United States. You can see this increase in cases in the United States compared to Europe, Japan, and Canada. And this is just, it's continuing to grow. These are thousands of cases, by the way, and it is gigantically skyrocketed from there. The next slide, please. Yesterday, the United States had more than 59,000 cases reported, the most ever. And there's a massive outbreak, as Dr. Wachter said, across the Sun Belt and into the West Coast, especially in the Southeast and the South, involving young people. There's been a 72% increase in cases nationally over the last 2 weeks, and 5 states set single-day records yesterday: Missouri, Tennessee, Texas, Utah, and West Virginia. So there are over 3 million cases that have occurred in the U.S. and 132,000 deaths. The next one, please. If you look at the map of the U.S., where red is bad, orange is almost as bad, and yellow is not great, this is what it looks like with this sort of broad swath of infection across the South. I mean, Florida is almost completely colored in, as is East Texas. There's also a secondary focus in the Middle West, starting in Western Pennsylvania and going through to Iowa and Minnesota. And then farther out here in the West, there are cases that run up and down the whole West Coast, which in many ways are a continuation of the same phenomenon that's going on in Mexico and into Canada. The next one, please. Let's just give you some idea about California. You can see here on the left with the state map by county. There's been Southern California continues to be a major focus of infection, starting in the Southeast with Imperial, Riverside, Orange, San Bernardino, Los Angeles and Santa Barbara. Ventura's also had a lot of cases here very recently. And then over the Tehachapi's up through the San Joaquin Valley, you can see all the solid dark brown of cases going all the way from Tulare up to San Joaquin counties, right in the middle of our Fresno catchment area. There are also cases now more cases in the Sacramento Valley. Those 2 dark brown counties are Colusa and Glenn counties that are very small, and these probably represent cases in agricultural workers. And then finally, in the northeast of California, that's Lassen County. That represents a prison outbreak in Susanville. And down in the Bay Area, the dark one is Marin County, which has its own issues, but also has the large prison outbreak at San Quentin added to that. The only counties that remain case-free or recently case-free in California are pretty remote. Alpine County, the one right by Lake Tahoe, has a population of 5,000 people. For any of you who want to be on the board of supervisors, pretty easy to get there, I would guess. So California has 292,000 cases and 6,722 deaths. You can see the case counts are going up. Really, the point of inflection for many of these outbreaks is Memorial Day, with increasing case counts from the 25th of May on. Deaths in California are relatively flat. These are still 60 to 70 additional deaths per day, and you can see how there might be some upward trending here of late as the numbers just get overwhelming. Imperial County in particular, in the far southeast, has been truly overwhelmed and has transported out more than 500 ICU patients, some of whom we have in our ICUs. The next one, please. People say, what are the drivers here? Well, there is some to some degree community transmission coincident with the lessening of restrictions, specifically bars, nightclubs, not nightclubs, bars, restaurants, retail, manufacturing, construction, and a lot of these are in Southern California and have been driving the outbreak in Southern California, especially in places like Orange. The other thing that's happened is that there's really a statewide outbreak of COVID-19 among low-income, densely housed Latino essential workers and their families. This is a pattern that we've seen from the beginning. This is the pattern that Diane Havler and her colleagues were able to document so well in their mission district studies. And it really remains the kind of the crux of the problem in California. These are not necessarily urban populations. We're seeing this in the rural agricultural parts of the state as well. On top of that, there are institutional outbreaks, with San Quentin now as leading the show with well more than 1,000 cases in a prison population. I think Dr. Williams will probably say exactly what it is, but it's about 3,500. And I can tell you the Chan Zuckerberg Biohub is working overtime to run specimens from the San Quentin outbreak as they try and sort out who's infected and who's uninfected. We also have nursing home outbreaks, thankfully none very recently, but there have been nursing home outbreaks in the Bay Area as recently as 3 weeks ago. The other thing we're doing, and this is sort of part of the second bullet, is that we've gotten a lot better at targeted testing. So we have more testing, even though it may not feel like it. California is testing more than 100,000 people a day, but we're targeting the testing. So rather than keeping these very low proportions of positive tests, like 3 and 4%, as we test a lot of people who don't have particularly high risk, we've learned how to get deep into communities and set up testing programs. I'm specifically referring, for instance, to in the Fruitvale area of Oakland, where La Clinica has set up large testing capacity to try and screen through that population and get people isolated who are infected and quarantined who've been exposed. Like San Quentin is the classic classic example of targeted testing, where, as I said, at least the last time I looked, the proportion of positive tests was something like 72%. And then finally, in Southern California, there's been a partial reopening of the border with Baja California, with increased communication going both directions, with some cases coming into the U.S. and some cases from the U.S. going into Mexico. But it's that's one of the issues that happened in Imperial County, where U.S. citizens who living in Mexico came back into the U.S. to seek medical care, which quickly overwhelmed their healthcare system. The next one, please. This just gives you an idea of what your county's doing. You can see increasing trends in Alameda, Santa Clara, Contra Costa, San Mateo, Solano, Sonoma, and Napa. And the only counties that have decreasing rates are San Francisco and Marin. That's because Marin's had this high spike due to San Quentin. Overall, in the Bay Area, we've had 31,845 cases, again, which have gone up since about the third week of June, and may have peaked out, may have. And we've maintained a relatively flat and relatively low level of mortality. This first crossbar is 5 deaths per day. We have 629 deaths total. The next one, please. And this just shows you San Francisco's current 7-day moving average of cases. We're running up in the past, we were running in the 20s and 30s. Now we're running in the 40s and 50s in terms of new cases. Okay. Currently, we're at the average of 43 cases. Now, since we're going to be talking a little bit about pediatrics today, I thought I should bring people up to date on some of the data on pediatric cases, and I'm grateful to Ted Rule from Pediatrics who's helped me with this. In Alameda, there have been 737 child and adolescent cases under 18 that have been reported. There have been no deaths, whereas among adults, there have been 141 deaths. In San Francisco County, there have been 366 child and adolescent cases and 50 and 3,705 adult cases with 50 deaths. And in the remainder of the state, there's still no pediatric or adolescent deaths compared to the rest. Now you'll see that pediatric cases run roughly about 10%. Pediatric and adolescent cases run at about roughly 10% of the total case counts. The next one, please. Now, I've talked about some of this stuff before, but I just wanted to run back through it to help set the stage a little bit more for Dr. Bardach. So why are children less likely to get infected and to transmit compared to adults, which is pretty much of an observed, something we've been observing since the beginning of the epidemic. A group in New York was very interested in ACE2 gene expression in nasal epithelium, in basic research on asthma, and it got nasal biopsies from 305 participants ranging in age from 4 to 60 years of age. Now, compared to children under 10 years of age, as you can see over here in the left-hand panel of the far left whisker plot, the number of the expression of this gene goes up as you get older, and children have about, I don't know, it's not half, but it's about 2/3 of the level that 18 to 24-year-olds have, and 10 to 17-year-olds have something in between. These are all significant differences. So the kind of biological question that arises from this, if the ACE2 gene is so important in the physiology, the pathophysiology of this infection, it's the place where the receptor binding domain locks in to get into and sets up the fusion with the cell wall. If the fewer of these receptors you have, the less disease you should have. At least that's the way it's going. But that's the kind of the physiology that underlies this. The next one, just to speak a little bit to some of the epidemiology. CDC did a special issue on children a couple of months ago. Not really much of this has changed. We are seeing more cases in children, obviously. The ones of the children who are hospitalized, most are infants, and there have been a handful of deaths. The next one, please. I think this is a remarkable study, which was done. Look at the community column in the little table. This was a remarkable study that was done in Iceland. And Iceland's a place where people tend to stay indoors in the wintertime, as you might imagine. And they did nasopharyngeal and oropharyngeal swabs for RT-PCR, for viral RNA, and they found zero out of 848 positive specimens in children under 10 years of age. As they got older, it was the same as the adult prevalence. So I think that's a remarkable fact, especially in a population that's as indoors as much as the Icelandic population. Having said that, the population of Iceland is about the same as the population of Marin, just so people understand the numbers we're dealing with here. The next one, please. And then the question is from whom and to whom does children spread infection? Chu in Lancet Infectious Diseases looked at 36 children under 16 in Zhejiang province in China. Of those 36 children, fully 2/3 had been exposed by a family member. 4 had been exposed outside of the house, and 8 had been exposed to both. So out of the 36, 32 had been exposed by a family member. And you can see here on the right, the infected contacts, according to the age of the source patient. The purple are infected contacts. You had to get to the 19 to 29-year-old band before you started to see infected contacts. And that's the same kind of thing right below. And these are Dutch. The panels here are from the Netherlands. The next one, please. There have been some outbreaks that have been reported where people have looked at this fairly closely. In China, there was a zoo. It looked at 31 household clusters in the early days in Wuhan, and only 3 of these was there the index case a child, and that contrasted with influenza, where 50% of the clusters, family clusters, had a pediatric index case. In France, there was a high school outbreak in the Haute-Savoie with apparently something like 40% seropositivity among 15 to 17-year-olds. Remember what I said about the receptor was that it's when you get into the 10 to 17-year-old age band, it's starting to look a lot more like the adult patterns of disease. In France, there was another school investigation from one PCR positive symptomatic pediatric case with 112 contacts and no subsequent transmission. In Australia, there were 18 cases investigated and only 2 subsequent cases in students among 863 close contacts. And this panel on the right is this French high school outbreak. The next one, please. Now, that would all be swell. We could say children don't get infected very easily. If they get infected, it's really only infants that end up in hospitals, 2/3. Why don't we just let it go, right? However, there is this multi-system inflammatory syndrome in children. That's a consequence of COVID infection. There was a large review of national data published in the New England Journal last week. This is from CDC, and they reviewed 186 cases. It seems as if the incidence of the syndrome is increasing in the United States, as you can see in the left-hand panel. It tends to be concentrated in places that had outbreaks relatively earlier on, like New York, New Jersey, and Michigan. So it's this is the countervailing argument. You can say, well, children, they don't transmit very much. They don't get infected very much. If they get infected, they don't get very sick. But here is this horrendous syndrome, albeit uncommon, that is something that we have to consider. And the next one, please. So just to give you one country's opinion on this, the Norwegian Public Health Institute, we've not found any research reports that have calculated the effects of school kindergarten closures on the COVID epidemic. There are a number of systematic reviews on the issue, but they're based only on studies done in connection with influenza epidemics, in which schools play a huge role. There's no 2 ways about that. It's highly uncertain how relevant the experiences from influenza epidemics are in connection with the COVID-19 epidemic, as it's quite possible that children play a small role in the transmission of SARS-CoV-2, as opposed to what's the case with the influenza virus. So we now have a number of European countries that have reopened schools. The Asian countries have reopened schools. Dr. Bardach and I scour the press every day to look for school outbreaks. There was one reported this morning from Davenport, Iowa, where it was either 4 or 10. Naomi may remember better than I. Kids had elevated temperatures and they closed the school. No etiology determined, no symptoms suggestive of COVID aside from fever. So we'll have to see how that one plays out. However, saying all this stuff about elementary school children is one thing. High school children, college age adolescents and young adults, and probably even middle schoolers, given an outbreak in Israel, are going to look a lot more like adult outbreaks than what we'll see in elementary schools, I think. Thank you. Happy to stop there and answer questions.
Great. Thank you, George. It's always fascinating. So many of the questions that came in were less about the pediatrics, although we will certainly get to that, and more kind of general what's going on questions. So let's start with what's going on with aerosol versus droplets. What's the debate about, and what what happens if it turns out that what's the consequence if it turns out to be aerosolized transmission?
Well, if it turns out to be aerosolized transmission, we've missed 1.4 billion cases in China. Just so aerosol, everybody would have it, frankly. So there is clearly aerosol transmission, but it's mostly in ICUs and ORs where people are being intubated and are having their lungs instrumented. That's why we want to wear PAPRs. How much aerosol transmission there is outside of those settings seems to be minimal based on epidemiology. The letter to WHO was done by a lot of people who are basically, it's a lot about the kind of the mechanics and a lot of engineering kind of logic about looking at droplet spread, looking at pictures of droplets and trying to measure it. In point of fact, there's only been one outbreak that may have been caused by aerosol transmission, which was in a restaurant with a vent blowing from an infected table that had an infected person to the next table over. So in the 10 point whatever million cases that we've seen, aerosol transmission does not appear to be a major factor. Again, it's a major factor in nosocomial transmission in ICUs, ORs, emergency departments. But aside from that, it doesn't appear to be a major factor.
I still get confused about this. It feels like kind of almost a little bit of a forced duality, that it's one or the other. You can imagine a world where there is some aerosolized transmission, but you just need a big slug of it, and it's unusual because of the dose of virus that you need. It feels like there's sort of camps here, and yet I wonder, is there more subtlety?
Well, of course, there's more subtlety, because you're going to need a certain inoculum size, right? You need a portal of entry, and you're going to need an infectious inoculum. And to the extent that aerosols exist, which there's no doubt that they exist. They clearly exist in the OR and the ICUs. To the extent that they exist outside of those settings where people's lungs are being instrumented, I think that the inoculum size may not be large enough to cause disease in very many people. Okay. The other thing to think about is maybe the severity severity of disease is a function of inoculum size. The lower the inoculum size, the less severe disease you have, which is at least one of Monica Gandhi's theories. That might be one of the benefits of everybody wearing masks, is that if you do get infected, you're going to get infected with a lower inoculum, and we're going to have less severe disease.
Okay. If your point about essential workers and why they're responsible for some of the spike, but that's been the group that's been allowed to or forced to be out there all along. So why the spike now, as opposed to why weren't we seeing more of that early, particularly in California?
Well, we saw a lot of it early on, and it's, just as more people get infected and more people have the opportunity to get exposed, the epidemic will grow. And I think that's a large part of what we're seeing. Now, I couldn't put a number on it, but the contact tracers talk about like 90% of their caseload being Latino. It's a big, big chunk here in the city.
When talk a little bit about the cases versus deaths thing, and it looks like we are seeing spikes in deaths now in Texas and Arizona and Florida, still not seeing it in California. So what explains that?
Well, the easiest way to explain it is just lag times, right? That there's a certain, everybody will eventually catch up. Their mortality will catch up. I think it's probably, though, it's more subtle than that. And I think at least in some of those states, there really is a much younger population that's getting infected. And while they're filling up the ICUs, they're not dying. I think in Houston, in the big hospital there, Bentob or whatever it's called, something like the ICU was filled up with 20 to 40-year-olds. At least that's what we heard anecdotally. One of the interesting things, though, is a curve from Florida, which I didn't show you, which has increasing case counts by age groups. And you can see that it's going up in the 20 to 29 and the 30 to 39, but it's also going up in the 70 to 89s. And the idea is that as this younger population gets infected, somehow that's getting over into the older population as well. And that might be some of the mortality spike we're seeing in Florida.
Okay. Maybe last question. Everybody, I think, we've gotten a few questions about the test positivity rate. it's really hard to get your arms around sort of what it means and what it means when it's going up and what it means when it's going down, and in the context of more testing. So can you try to explain that?
It's not explainable, right? So
It does not explain. Okay, thank you very
no,
much.
I mean, you know, so Dr. Birx from the White House Task Force 1 year ago was yelling at all of us in PEPFAR about how we weren't finding enough cases, we didn't have enough yield because we weren't targeting our testing sufficiently well. Now we're getting yelled at about doing the exact same thing, the exact what you wanted for HIV. So I think you have to get better rubrics for this stuff. And I think you have to be able to differentiate outbreak situations from screening of people who are asymptomatic. I think if we knew who was asymptomatic when they were getting tested, that might be a reasonable rubric to follow. But somehow we have to pull out all the San Quentin cases if we're going to follow this. We're going to have to pull out nursing home outbreaks. We're going to have to pull out people who are sick, who are showing up in the EDs. Then I think it's probably an okay rubric. But we have to sort it out a little bit better than it's being sorted out now. As a crude proportion, I don't think it's particularly helpful.
All right, well, let's move on to the schools. You've set the stage incredibly well, and let's bring on Naomi Bardach and Liz Rogers. I think Naomi's going to give us a presentation with some slides, and then we'll bring Naomi and Liz, and I believe George will come back on as well to talk through some of the issues. So Naomi, thank you for being here. Look forward to hearing you talk. You're on mute. No, you're not.
Thank you so much. My pleasure. Thank you for inviting, allowing us to give this presentation. So we're talking about safe school reopening. What are the key questions and the evidence behind them? So next slide. A couple of disclosures. I'm a pediatrician and a parent, so I am invested in the idea of kids going back to school, but I'm also presenting this data as a doctor and a policy researcher, so thinking broadly about public health and multiple populations, not just kids. Also, our understanding of this disease is rapidly evolving. What I tell you today may be different tomorrow based on emerging research. Literally, I have a slide that I put in yesterday from a New England Journal of Medicine article that just got published out of Italy, which actually changes things a little bit. And then finally, this is a team sport. I want to acknowledge many, many thought partners and collaborators who have contributed to thinking behind this slide deck, as well as some of the slides. Next slide. So the overview of the talk, can we reopen schools? And what do we know so far to inform that question? Also, how do we reopen schools? I'll also be talking about how do we create a learning educational system similar to our idea of a learning healthcare system. I actually think it's extraordinarily important that we do a learning educational system as we reopen. And then I'll touch on the need for unprecedented collaboration. We're not going to be able to figure this out if we don't do a lot of work across multiple disciplines within and outside of healthcare as well. Next slide. A couple of school reopening considerations. It's really important to frame this conversation with sort of compared to what question. So it's really important to remember that the pandemic has caused economic devastation, as you know, and financial instability across all communities. There's a limited illness burden in children, as George just pointed out, but families with children bear a large brunt of the economic devastation mediated through school closures mostly. Resulted in the loss of education for all kids in the spring. It's starkly deepened existing disparities for low SES students. It led to increased anxiety and depression for actually a lot of students all across the SES spectrum up and down, as well as many adults. It led to extensive unemployment and job loss. It entrenched gender inequities and pay gaps as women shouldered the homeschooling and childcare burdens. And then there are signs of increased child abuse, domestic and intimate partner violence. The data is not great on that, but data from prior recessions have shown this trend. Next slide. So it's really important that we frame that's some of the driving forces of doing school reopening. However, we need to reopen schools safely. Even if it's a crucial next step, there is a concern that children may be viral vectors and a substantial source of transmission. George just gave great data as to why it's different than influenza, but in influenza, children are a known source of transmission and school closures are shown to be effective. And a lot of people just have this mental model in their heads, kids are viral vectors. I'm just going to get whatever the kid has, and it's going to make me sick and make my community sick. And so teachers and staff are concerned about getting it from children, and then families, particularly with adults with chronic illnesses or children with underlying conditions, are concerned about children bringing it home. Next slide. In this conversation, I really want to highlight that teachers and educators are key partners. They historically are underpaid, so we shouldn't make this a worse situation than what they already are working with. Schools, particularly in California, are underfunded. A lot of schools don't have soap or paper towels for hand washing because they don't have the budget for it. A third of the teaching workforce in California is older, and many have chronic illnesses. So it's really helpful to remember that what's good for teachers is actually good for students as well. So the school reopening goals have to be equity in terms of getting kids back, making sure all kids get a good education, but also has to be focused on safe reopening or safe education. Next slide. The good news, we know a lot more than we did in March. Next slide. And so we have a lot more to inform us. What follows is a summary of the data on COVID in children and transmission. It's not comprehensive, but I am trying to highlight themes and a few key articles and reports. And then I'll, at the slide at the end, will actually point you to like a very, very comprehensive set of data for anybody who's interested. Next slide. So what is our summary of findings? These first three bullets, George already told us about quite nicely. Children get COVID less often and are less ill. They most often get the disease from an adult, often from household contacts. Children do not seem to be the major sources of transmission to each other or to adults. Transmission in elementary schools likely differ from high schools. And then staff and teachers as adults are more likely to transmit to each other. I wanted to highlight these last three bullets, including we have limited data on middle school age children and on preschoolers. I just wanted to highlight this one particular thing. So Iceland shows us what is possible with with just those 0 cases, and California shows us that there's 0 deaths. Spain shows us what I think is more probable. There's a recent article in the last week from Lancet about antibody prevalence in the community from April 27th to May 11th. With 3.1% of children less than 10 having antibodies versus 5% overall with antibodies. Iceland shows us that you can have 0 cases, but we are probably going to look more like Spain with actually a decent number of cases. You know, it's going to be less than adults, but they are going to happen. Next slide. The ACE2 receptor study, I think it's so helpful. I just wanted to point out one small limitation in terms of our how useful it is going to be to us. They only report by age categories, so we don't know if there's an uptick during or after the middle school ages. So trying to understand what to do with middle school is going to be a little bit tricky in the 10 to 13-year-old age group. Next slide. This also, for the idea that children generally get COVID from adult household contacts, there are a lot of good sort of contact tracing articles, and this sort of highlights a couple of them. In most of these cases, there's very few index cases in kids that actually seem to be the initial case in a household. So in that first review, it's 10% of household clusters. In the Chicago cohort, it's about 13%, although there's some percent that they weren't able to determine. In a Swiss cohort of 39 hospitalized children, it was only 8% of household that the study child developed symptoms prior to any other household contact. I wanted to highlight, though, that 85% of adult household contacts developed symptoms in that study versus 43% of other kids, the siblings in the house. So the implications there are that adults are the likely primary source, but also in terms of transmitting kid to kid, siblings did not get it from the index case very often, nor even from the adults. So that just goes back to educating us a little bit about our understanding of how kids pass it back and forth to each other and just their general tendency to get it. Next slide. Very important, this is the hot off the presses New England Journal of Medicine article yesterday from Italy, a cohort of 100 cases seen in the emergency department at the height of their pandemic. For them, there was 55% of their cases had an exposure to an unknown source or a source outside of the family for those kids. So that's very different than those 8%, 10%, 13% that we just saw on the last slide. It was in the context of extensive community spread and a very slow closure in Italy at the time. But it's helpful to see we'll have to learn more from that experience and what might have been happening there. Next slide. This slide highlights a couple points that transmission is not common in children. School closures contribute little to the epidemic control. The first study is a modeling study showing that school closures would prevent only 2 to 4% of deaths, which is much less than other social distancing measures. There's really interesting data from the YMCA that is only published in the New York Times, but it shows kids 1 to 14, so that does include our middle schoolers. They had up to 40,000 children in over 1,000 sites in their emergency care childcare sites. So that's for essential workers. No children, only a few staff and parents tested positive, and there were no records of more than one case at any site. So even in the United States, we can actually do this. We can actually have very few cases in places that are open in person. And then to highlight the case study of a French 9-year-old with co-occurring influenza and COVID-19, George touched on this. There was multiple contact tracing, and there were 0 cases. He went to 3 different schools, 0 cases, but there were influenza cases in those schools. So the implication is that the transmission of COVID-19, again, is limited, but the influenza is different from COVID, and school closure in influenza probably doesn't extrapolate to COVID-19. Next slide. Another important thing to touch on that also just came out within the last couple of days is there are outbreaks in Texas daycares and increase in Oregon cases for kids under the age of 10. So if people hear about it, I think it's helpful for us to talk this part through. Oregon had a 5-fold increase in kids under the age of 10 in May to June. Public health officials there are saying they think it's due to community transmission. This is also media reports. So we don't have a whole lot of information about it, but meaning that this is probably, they don't see any clusters. There was one daycare outbreak of 28 kids, but otherwise there weren't any clusters that explained it. And so mostly that's probably the household contact story again. Texas has 950 cases in daycares, about 1/3 in children and 2/3 in staff members. Again, no information regarding index cases or transmission in the daycares versus community spread. And then there's limited shelter-in-place policies in Texas at the time, leading to implications that when there's no sheltering and high community prevalence, children are more likely to get COVID, is what we're seeing here. In low prevalence and shelter-in-place policies in place, there are very limited cases in children. That's the YMCA data. And so I think one important policy corollary as we try and think through what all this means is that if our communities do need to go back under the second wave and the second surge, if they go back to stronger shelter-in-place policies, schools may still be able to safely provide some in-person education with proper precautions and testing in place. Next slide. And then one other study just to touch on, because it was sort of got cited a lot. There's a study of German children initially reporting similar viral loads in children and adults with a claim that therefore the infectiousness might be similar. However, there were 2 reanalyses of that data suggesting that there actually is an increase in viral load by age. So, and then probably more importantly, the epidemiological data just don't show large transmission in children. So what you measure in somebody's nose and children's noses doesn't seem to actually be related to the fact that they would be as infectious as adults. That's just not the story that we're seeing. This study doesn't really inform us substantially regarding school transmission. Next slide. This is something, George touched on this quite nicely already, the outbreak in high school in France prior to closure, and then some media reports of school cases in Israel. The high schools had the highest number of cases in that situation. One little small interesting detail that I found in a news report yesterday was that some schools actually stopped masking during a heat wave prior to those outbreaks. So it might be that was part of what was going on. Next slide. So what are the sort of final implications of all this data? You know, we know more, and I think the take-home message is we have more control than we did in March. The data suggests that school reopening is possible with public health principles and testing in place, especially if adults are following social distancing, masking, public health recommendations. The benefits to reopening with safety protocols in place likely substantially outweigh the risks for teachers, children, and communities. That being said, we need further data in our local and national context, and then particularly data regarding reopening in high schools versus elementary versus middle schools. But I would say to anybody who's feeling like they are advocating for something, I think the advocacy is probably best to focus on controlling community spread and supporting schools and teachers to go back to school in a safe way with adequate budgets for testing, cleaning, and additional educational training for hybrid teaching. Next slide. So how do we reopen schools? Next slide. And this is like a huge topic. I am not going to go deeply into it, but I think there's a couple of principles that are going to be helpful, and then I'll refer you to resources. We need to do both risk mitigation. We know we can't stop COVID, but we can mitigate the risk of getting it. So risk mitigation and quality education are the goals as a society, and what's doing right for, I think, everybody, including teachers. There's a layered approach, small, stable cohorts in order to decrease contacts and make it actually easier to to do contact tracing if there is a positive case. Face coverings, physical distancing, hand washing. Symptom screening is actually probably going to be helpful, and I'll talk more about that in a minute. And then robust testing capacity in place. I bolded those things because a good ventilation, cleaning, and disinfecting, also core pieces, but potentially much more difficult for schools to do in terms of budgeting, particularly the good ventilation. And then cleaning and disinfecting, it doesn't seem to drive it. And so the idea, some schools are like, I need to do deep cleaning every 24 hours. I need to clean the bathrooms once an hour. That's not the best use of resources compared to these other approaches. And then hybrid models and phased in approaches allow for learning and flexibility for teachers coming back and for kids with chronic illnesses coming back. Next slide. So there's some key messages from the Department of Public Health, which I'll let you guys look up. I think the one that's probably most important is the addressing adult-to-adult transmission and adults as sources of infection. It's very easy for us in break rooms to feel like we're safe because it's adults. Take off your mask, eat some food. So that's really quite important for everybody to, I've seen it several times in summer camps and also even in my own research team that people sometimes do that. So it's important to note that. Next slide. So creating a learning educational system, there's a few points to make here. Next slide. James Baldwin has a important quote, ignorance allied with power is the most ferocious enemy justice can have. I think appropriate for this setting. Next slide. So the key research question to focus on is how might we reopen schools with an equitable, least restrictive, but safe educational environment? There are a couple different potential research designs. Why don't you do the next slide? There's going to be natural variation in policies and approaches through schools. And so one really important thing to point out is that we probably, because COVID symptoms are so nonspecific, we're probably going to actually end up doing a ton of testing just based on symptoms alone, because in order to get back to school, kids actually need to be getting tested. That is an advantage for us. It actually means we essentially are going to get some decent amount of testing and sort of almost asymptomatic testing. And there's an opportunity to leverage it for ongoing learning with online screeners linked to the student test results and school, which school they attended and what those policies are. It needs data planning and infrastructure, but it is potentially feasible with the right partnerships. Next slide. And then there's potential for a prospective trial, which is basically a randomized control trial, this is called a step wedge design. And Oakland Unified School District is actually doing these kinds of phased in approaches. If we can, I'm working with multiple partners trying to see, can we actually do it as schools go into their next phase? If we can do it in a randomized way, one school at a time every week, we actually might be able to learn quite a lot with standardized weekly testing of a random subsample of kids. Next slide. And then one note about testing feasibility, we're doing a camp pilot to test the feasibility of collecting anterior samples. So kids can actually do that themselves. They don't need as much, you don't need PPE for it because they're self-collecting 6 feet away. It's very acceptable to students and adults. They're quite good at it. And it also, if we can train the camp staff to assist in collection, which builds capacity for ongoing testing then. Next slide. And the last piece of the learning educational system is tracking other important indicators. Right now, we focus on cases, hospitalizations, and death, and we're lacking indicators for other health effects. So we need to be able to capture those balancing measures as well. Next slide. And I'm finishing up. Bob is telling me I need to finish, which I appreciate. I'm sorry, we lost connection twice. So there's a need for unprecedented collaboration. And next slide. I just want to highlight, there's a lot of talk broadly about pediatricians are trying to force people to open up schools, et cetera. We really, I think the focus needs to be on COVID is really, really hard, and we have to work together as multiple communities together in order to try and actually mitigate the effects everywhere: schools, kids, teachers, the economic issues in our society. So that's sort of the perspective that I think is the most useful one. Next slide. And this is team science on steroids. Lots and lots of people, lots and lots of expertise has to come together to talk about this. Next slide. And then there's I wanted to highlight, and this, Liz will be able to talk about this in the 2 minutes we have for questions, which is the collaborative task force on school reopening, which are faculty members from pediatrics that focus mostly on many clinicians are being asked to give advice to their schools about how to reopen. And so this is a group that's really trying to bring together thinkers and everybody marshaling the data in order to get a sense of what's the right way to reopen. Next slide. And so the task force goals are to give that space for discussion. And if you're interested in joining, please email Elizabeth Rogers at UCSF. And I think that's it.
Great. Thank you. Sorry about the technical stuff. Happens.
Yeah, my apologies.
Liz, why don't you come on, and George as well. And so, Liz, let's turn to you. You're still on mute, so if you can unmute yourself. Why don't you kind of introduce a little bit about what you're doing and kind of any reactions you have to what you heard already?
Yeah, I mean, I think I wear 2 major hats. One of them is in faculty experience. And so we were hearing that a lot of our faculty members, whether pediatricians or others, were being asked to inform their local communities on how to really implement this guidance. And so we've brought together this task force, and I think the real power of it is that we all, as in everything, use our own lens to interpret data. And so we all have a different tolerance for assumption of risk as individuals, parents, and providers. But when you bring together a group of people, we have health equity experts as well as infectious disease experts, developmental and behavioral pediatricians. We can sort of broaden beyond our own biases and our own lens and try to think about it as representing, healthcare professionals generally as we go out there.
So it's an incredibly challenging topic to get right, and I think we all have our biases going in as well. What do you counsel to, let's say, a parent of a middle schooler? It sounds like middle school is that time where we're not quite like the elementary schoolers and maybe not quite like the high schools. Parent of a middle schooler who, let's say, someone at home is sick, has cancer, and is really not only worried about the kid, but worried about the kid bringing it home and sees all this data and maybe he's a little reassured, but what would you tell them?
I think the hardest thing is actually one thing is advising schools, individual schools and districts on how to be flexible. And then there's a whole nother question on how do you actually guide a specific family to make a decision. So I think when we're working with schools, we really are trying to, empower them and encourage them to provide a lot of flexible options for families, so that families can even come in and out depending on where their risk assumption is, based on their individual circumstances. So middle school is a really tough one. We feel safer about the younger kids based on the data. And I think it's all about working with a family to understand the data and to really help schools come up with flexible options.
Okay, this may be more of a George question. One of our viewers asked about pooled samples. So talk a little about testing strategy. Naomi brought up the issue that there's got to be testing. We're hearing about test shortages, so there's that. But then are there more creative strategies to do testing if you're trying to get the kids back in school?
Sure. I mean, it depends on what you're trying to find. And if you pool samples, you lose sensitivity. So if you're looking at cycle times like 39 or 40 cycles, really right at the edge of detectability for very subtle infection versus somebody who's going to be spreading it to lots of people who would have a cycle time of 12 or 13 or 14.
Just tell us I'm not sure everybody knows what cycle time is. What does that mean?
So in a PCR machine for a polymerase chain reaction, every time you're trying to take a little bit of RNA and then amplify it, make more copies and more copies and more copies up until you can get to a limit of detection. So think of it as like turning a crank. I mean, Joe DeRisi would roll over in his grave if I said this, but you turn the crank, that's one cycle, another cycle. So you're making it 1, 2, 4, 16, it spreads out, right? And so the number of cycles you need to actually detect it is inversely proportional to the viral load. So the fewer cycles, the higher the viral load, the more cycles, the lower the viral load. It's up at that very high cycle threshold of something like 38, 39, 40 cycles that you're going to lose sensitivity. Below 35, you're probably not going to lose much sensitivity, but if you're really trying to find that last little bit of people who have really truly, or who are infected, right, who have the virus present, but are probably not very infectious, that's where you give up, that's where the pooled samples don't work.
So you're going to miss some people if they have a relatively low
Yeah.
viral load, but is the benefit of just efficiency of testing maybe worth it?
Maybe. I mean, it depends. I mean, we've done it before for other types of diseases. I'm kind of a fan of it, but we're not trying to detect this very narrow margin. And I think telling parents and school boards that we're going to have a lower standard of detection just so we can do more tests is probably not going to fly.
Yeah, unless we really don't have enough tests to do what we really need to do.
Yeah.
Naomi, I hear pushback periodically that this would all work fine if everybody wore masks and kept a distance, and they'll say, have you ever been inside a middle school or an elementary school or a high school for that matter? So can you sort of take us through the reality testing of how practical all this stuff is?
So I can jump in here a little bit ahead while Naomi's trying to electrocute herself. Where it's not going to work is for 2 to 5 year olds, right? The statewide order starts at age 2, and I have a picture of my granddaughter, 2-year-old granddaughter, trying to keep a mask on. It looks like she's going to amputate both of her external ears from yanking on the thing so hard. It's just not going to work for kids that little, and I doubt that it's going to work for 5 or 6 year olds. But I think maybe at 7 you can start getting there. It's tough. It's going to be tough. It's going to be tough.
Yeah, I think. Can you guys hear me now?
Yeah.
So there's one other layer also that I think is extremely important, which is that the transmission that we probably need to worry about the most in the school setting is actually adult to adult, and then the high schoolers. So the little kids, I think my concern is not too much about the little kids based on the data we have in terms of them passing it back and forth to each other. That being said, I've been doing this indoor testing, and there's a decent amount of pretty good mask wearing even in the younger kids. So it's a little bit of window dressing, but they're able to actually participate. I haven't seen the 2-year-olds do it. You make a good point, but I think even the kindergartners are actually able to do it decently.
Great. All right. I'm sure we can go on for a long time, but unfortunately we're out of time. So thank you so much for helping us understand this issue. It's really tough and seems like one of the few happy discoveries in this disease, the infrequency with which it hits kids and the infrequency with which they transmit it. So trying to take advantage of that seems like a good idea. So thank you for your work in this area, and maybe we'll check back in a month or so and see how things are going.
Thanks.
Let's switch gears to our final segment, equally important, equally vexing, and that is the issue of the prisons in San Quentin. And let me just reintroduce Bree Williams and David Sears. And so I think Bree is going to start with some slides, and then we'll hopefully have some time for discussion with the two of you. So Bree, you are on.
Great, thank you. And there you go. Thanks so much for inviting us to speak about the COVID-19 outbreak at San Quentin. Next slide. Amend at UCSF draws on public health, human rights, and Norwegian correctional practices to transform toxic, unhealthy prison cultures into ones that optimize the dignity, humanity, and health of residents and staff alike. Next slide. We exist because between 2.2 and 2.3 million Americans are incarcerated, and an additional 11 million cycle through jails each year. An alarming 1 in 3 Black men and 1 in 6 Latino men have a lifetime risk of incarceration. Next slide. Many incarcerated people are in poor health. They live in unsanitary and overcrowded environments like this. And over 170,000 across the nation are older adults, meaning over the age of 55. Next slide. The COVID-19 pandemic really reminds us that our health is interconnected from the community and into the prisons and jails and back again. Hundreds of thousands of staff enter and leave jails and prisons each day. Staff bring infection back and forth from the community to work and from work to the community. Next slide. In a study that we conducted last month of correctional officers across the nation, we heard many upsetting quotes. One, we no longer call ourselves essential. Now we say we're sacrificial. And another, I am my mother and father's ride for appointments and shopping. I need to be healthy. Yes, I know I signed up for this job, but none of us saw this coming. It's scary as hell. Too many people are not taking this seriously. Next slide. And residents, of course, are also terrified. This is from a Twitter account of somebody who's currently incarcerated in a prison that I'm not sure which one it is. My symptoms are getting worse, fighting waves of nausea, pounding headache, diarrhea. COVID-19 is bad, prison is horrible. COVID in prison is a humanitarian crisis. Less and less officers showing up to work each day. We haven't had a shower in days. Meals are getting smaller and ice cold by the time they get to us. So many incarcerated people have been wheeled out on a gurney. I can't keep track no more. Next slide. And there's reason for staff and residents to be fearful. In March, we had very few cases in prisons and jails across the United States. Now we have 70,000 publicly reported cases among both residents and staff. I think it actually hit 75,000 today. There have been approximately 700 deaths reported. 85% of the cases and deaths are among residents or prisoners, not staff. And these numbers are likely extraordinarily overcounted as there's inadequate testing and poor reporting, including no reporting in some states. Next slide. I'm going to switch to talk a little bit about the San Quentin, California State Prison outbreak, because that's what I was asked to speak about. But before I do, I want to make it very clear that San Quentin is one, actually pretty well-resourced prison in California's 30-odd prisons. And at last count, we had over 5,700 cases of cumulative cases of COVID in the prisons, and actually 31 deaths so far. So San Quentin is by no means the only state prison or population that's experiencing this. Next slide. So this slide shows confirmed cases per 1,000 people. As you can see in the blue line, we see California's cases per 1,000 people, 6 cases per 1,000 people over the last 6 odd weeks. In CDCR, California Department of Corrections and Rehabilitation, or the Department of Corrections in California, is the orange line. You see it's about 48 cases per 1,000 people in the prisons. San Quentin, on the other hand, has had a very different experience with 428 cases per 1,000 people. Next slide. So I'm going to switch to talk a little bit now about the San Quentin outbreak. Just a tiny bit of background. 50% of the population at San Quentin is over the age of 50. Hundreds, as you can imagine, have risk factors for poor health outcomes after a COVID-19 infection. On May 30th, about 120 patients were moved by bus from an outbreak facility in Southern California to San Quentin. And unfortunately, 14 of those patients tested positive for COVID-19 on or shortly after arrival. We were called on June 12th when there were 16 known cases at San Quentin. We were asked by the federal receiver, who runs the California healthcare system in California's prisons, federal receiver, to make recommendations about San Quentin's needs as the outbreak was unfolding. We visited the next day on June 13th. Our team includes people from UCSF as well as colleagues from the UC Berkeley School of Public Health. And approximately 36 hours later, we issued an urgent memo. Next slide. I'm just going to touch on some of our findings from our June 13th evaluation, which is available online. Most importantly, we predicted an extraordinarily high risk of rapid COVID-19 transmission that could easily overwhelm the prison healthcare system and inundate Bay Area hospitals, which is essentially what we've seen. This was based on our finding of quite antiquated facilities. San Quentin, if you've been to Alcatraz, you've kind of been to San Quentin. Many of the housing units were built in the late 1800s and early 1900s. As a result, they are extraordinarily poorly ventilated, including that windows are purposefully welded shut. There's extraordinary overcrowding, and so there are 2 people per cell stacked upon each other in 5 tiers or levels of cells. They all breathe out through open bars into a common atrium. The cells are 4.5 by 10.8 feet. When we were there was extraordinarily limited staff testing, and there was no limitations on staff movement between housing units. So a staff member could be in a unit that had an infection and then go to a unit that had no infection on their next shift. We found significantly inadequate staffing, but also training in how to respond to the threat of a large outbreak. It was essentially the staff that were there, that were always there. We saw extraordinarily delayed 6-day turnaround for tests, and residents were terrified. You can imagine staff were desperate for help. Next slide. We made a series of urgent recommendations, like I said, 2 days in the morning, 2 days later for the federal receiver, and I'll cover sort of the highlights on the next 2 slides. First, to create immediately an outbreak response team that was needed both locally at San Quentin, but of course centrally, because outbreaks, this is one of 4 outbreaks that are occurring right now, and there will continue to be more in the 30-odd prisons throughout the state. To immediately reduce overcrowding, primarily through decarceration, as that's required for all the public health strategies that we have to control transmission of COVID-19. To improve ventilation and sanitation immediately. To repurpose buildings at San Quentin for medical isolation, quarantine, and to immediately create a field hospital. Next slide. We also suggested the need to cohort staff to assigned housing units for their shifts, and they should be the same shifts and the same housing units each day, and to improve staff testing. To prepare for streamlined transfers to surrounding hospitals, and of course to engage in surge planning for medical and custody staffing that may end up becoming ill and not being able to come to work in the following weeks. Next slide. This is what has happened at San Quentin since we left. So towards the left side of the graph, you see where we went when it was 16, 17 cases, and we have now reached actually around 1,600 cumulative cases among people who are incarcerated today. Next slide. This slide shows a cumulative tests since the start of the outbreak and the weekly test positivity rate. I think the important thing to note in this graph is number 1, the blue bars show you how many tests have been done. And so there's a population of between 3,400 and 3,500 residents at San Quentin. And so 2,500 tests have been done by the beginning of this month, so 3 weeks into the outbreak. There's a few reasons for the lack of complete testing. Of course, there's some patient refusals, but secondly, there's massive staff shortages, and so some testing just can't happen. The weekly test positivity rate, as you can see, is really quite alarming at the height, reached about 70, almost 75%. Next slide. So what's happened since then in terms of patient outcomes? Well, hospitalizations, I think many of us have heard about this in the news. There are currently approximately 60 patients hospitalized in community hospitals really throughout the Bay Area and Northern California. This has held pretty steady in the last week, although additional patients are either refusing transfer but need it, or awaiting transfer or will soon need it. Staff infections, including among officers, nurses, and at least one physician, have continued to climb. So June 22nd, 43, by the end of the month, 102, and today I believe reports are around 200 and 7 residents have died thus far, with many in intensive care units around the state. Next slide. This is a quote from a physician at San Quentin, which is really was reinforced by most of the clinicians, physicians, but also other healthcare professionals working at San Quentin that we spoke with. I have to tell you how much I worry. I worry that victims will be blamed when we look back and talk about San Quentin. Our patients worked so hard to clean their cells and the surfaces of these ancient buildings. They cleaned them like they had a chance. They never did. This isn't their fault. None of the CDC guidelines prepared us for this. I just don't want any of them blamed. It's just not their fault. Next slide. As we've seen, of course, at UCSF and other hospitals around the state, prison outbreaks pose also really unique and significant challenges for clinicians practicing in community hospitals. Next slide. And I just want to take this moment to pause and say that there are some very important points that have to be remembered about ethical care for incarcerated patients. I think these 3 are the most important, but there are many others as well. Number 1, patients who are incarcerated retain the right to self-determination, meaning that they retain the ability to choose what medical interventions they do or do not want in the hospital, including at the end of life. They have the right to name a proxy, so they can name a family member or a friend as a medical proxy decision maker in the event that they cannot make the decision themselves. And not only is it a right, but really you would say it's not just a legal right, it's really a human right to communication, that patients at the end of their lives have the ability and retain the right to say goodbye to loved ones at the end of their life, either through video conferencing calls, phone calls, occasionally in-person visits, in non-COVID times. And this right really has to be approved, though, by the physician at the state facility, but nearly is always approved. Next slide. And to provide more guidance in the care for seriously ill patients transferred from prisons to California's community hospitals, Dr. Leah Rohrvig, who's the Director of Health Education for Amend, has developed a how-to guide for all California community hospitals that are accepting patients transferred from prisons around the state. This is available on our website and has been vetted by the Department of Corrections Legal. Next. So a few additional San Quentin updates. I'm nearly done. They have created an incident command center at San Quentin last week. It's led by the California Office of Emergency Management. We have exceptional involvement of faculty from the UCSF Division of Occupational Health now, who are helping to devise a plan for repeat staff testing, regular staff testing, and to identify optional housing for staff who are working in outbreak facilities and are concerned about returning home to family members. Additional housing has been brought to San Quentin in the form of tents and a 100-person field hospital with some limited kind of capacity, but more than the acute care setting. The current acute clinic that they have there is in construction and should be open this week. And the Department of Corrections, or CDCR, is engaged in statewide COVID-19 outbreak planning for all prisons throughout the state. Next slide. Just a few examples of Amend at UCSF's additional efforts. We were stunned to see that we received interest from 31 UCSF clinical and staff volunteers within 36 hours of speaking at the UCSF Town Hall last week. And UCSF is now coordinating that centrally, and I'll give you the links to those volunteer opportunities at the end of the talk. In addition, the UCSF palliative care clinicians, really through all three hospitals, are starting tablet-based consults at San Quentin, again, organized through the UCSF Volunteer Office. Dr. David Sears, who's presenting with me today in the question and answer period, provide testimony to the California Senate hearing of the Public Safety Committee about the need for a comprehensive COVID-19 response that's based in public health and medical science so that the events that transpired at San Quentin do not recur at our other state facilities. And we're involved in continuing outbreak investigations as advisors to the receiver, including evaluating more of a successful containment at California Men's Colony Prison in San Luis Obispo that should be ready in the next couple of weeks. Next slide. So I want to say thank you, of course, to the entire MEND team. I work with exceptional people. Every single one of these people could have given this talk, and I couldn't be more proud to work with each of them. Next slide. And to learn more about Amend at UCSF in general and our programming, please visit our website, amend.us. And we have a COVID tab for resources for correctional facilities, as well as patients and family members. And to volunteer, these are the two links. If you can't see them that well, or if they don't work, please email kevin.reeder, R-E-E-D-E-R, at ucsf.edu, and he will put you in touch with the people at UCSF who are organizing the volunteers. And with that, we're happy to take questions. Thank you.
Great, thank you. Thank you, Bree. David, why don't you come on and join us? There you are. Welcome. David, why don't you talk a little bit about the clinical aspects, which I understand you've been, it's been your special focus. So, this may be too tough as the first question, but one of our viewers wrote, with limited resources, remdesivir events and all that, how do you make decisions ethically about in patients on death row? That strikes me as a bonus question, but start a little bit about just clinical care in general, and then maybe if you want to address that, that'd be great.
Sure. I mean, I think it certainly depends on the degree of illness severity. So a lot of clinical care at San Quentin right now is happening in cell to try to keep people in a limited environment and prevent mixing with patients who may be negative. And then the establishment of the field hospital obviously will give more options for slightly higher levels of care within San Quentin itself. That said, individual patients within correctional facilities have the same rights to healthcare as anybody free living in the community. And so, there's been a massive effort to mobilize hospitals in the Bay Area, including UCSF, to care for these patients. And when they arrive here, they're entitled to the exact same care that everybody else gets. And so there have been some questions around the idea of some of the clinical trials or EUA use of remdesivir, et cetera, for these patients. And they are potentially eligible for clinical trials and remdesivir. There's a California law prohibiting medical research among incarcerated residents, but we have verification from the legal team in California Corrections that law does not apply when they are in community hospitals. Now, certainly IRB modification may be needed as well to make sure that those patients are allowed. But irrespective of incarcerated or not, death row or not, they're entitled to the exact same medical care we all get.
And tell us a little bit what can and can't be done in the field hospital. Does it change if you were to take someone who is not incarcerated and you were trying to decide on the threshold for hospitalization? How does the availability of this field hospital change that? And how does the complexity of hospitalizing a patient from San Quentin, does that change that at all?
Yeah, I'd rather answer that question once the field hospital is built, which will be within a couple of years. But at the same time, I think that'll, my understanding at least is it'll be somewhat akin to the CDU down in the emergency department, but probably with not quite as many resources. And the other thing that's important is just getting somebody who's incarcerated at San Quentin out to a hospital if they're sick enough is a process, right? And they need to go with correctional officers. There are issues around correctional officer screening as well, transportation, et cetera. And so that field hospital can serve as a place to give slightly higher level of care while somebody's waiting to get out and arrangements are being made in the community.
Yeah. Bree, this word decarceration, what does it mean, and what do you say to someone who says, this is a terrible situation, and I feel for these folks who are sick, but they're in prison for a reason?
I think that right now what we need to do is follow the science. So what the science tells us is that with incredibly overcrowded and unsanitary and poorly ventilated institutions, we're going to have more and more spread. And decarceration really says, the idea is that decarceration is really, I would actually use the word public health focused depopulation, use decarceration because it's a little bit of a shorter term. But really what that means is that there are many, many people in the prison system that do not need to be incarcerated at this point. They have exceptionally low rates, lifers, so people who have, for example, 15 years to life. They have, and who are much older adults, people with multiple chronic medical conditions who have been in prison. They have gone through 3 sometimes successful parole board hearings, 15, 20, 30, 40, 50 years incarcerated. They have a less than 3% recidivism rate when they get out. And so there are many people who really do not need to be incarcerated anymore, but our society, just like COVID has really made us have a national reckoning on a lot of different things that are happening in our society that, perhaps we need to think about again. Our society has really over-relied on mass incarceration, really warehousing of people for decades. And what COVID has made us do is really rethink the public health ramifications of this type of warehousing and overcrowding of our prison systems. And so when I say public health focused decarceration or depopulation, what I mean is that many, many people, like the lifers that I described, can be safely released into society. Many people could also, we could say, well, they're not finished paying their debt to society, but they're safe to be released. And so those people maybe would go out on a furlough. And maybe we can fight about whether or not they come back in 2 years or in 3 years when they have a vaccine, when we don't have these type of outbreaks. There are people who potentially could finish out their sentence on home release. We also have, or in home confinement with an ankle bracelet, for example. And we have other people who will be being released within 6 months, within the year. And those people, our team met somebody in his late 60s who had 6 weeks left on his sentence. And he was in an extraordinarily overcrowded unit at San Quentin. I mean, the risk of him being there versus going home 6 weeks early is really quite astonishing. It's astonishing to see him still there. So I think there are a lot of different strategies that you can take, but really what it boils down to is getting as many people out of the facilities as is possible allows you to not only create more effective testing plans, but then once you have the tests, you have the space to put people into housing that's either quarantine housing, medical isolation units, or regular housing.
And if you could roll the tape back, it sounds like when you were brought into San Quentin, the patients, we'd already were seeing the beginning of the outbreak, but it really began when these folks were transferred up here from the prison in Southern California. I understand partly because they were overcrowded and they were having something of an outbreak. Is that, if you could roll the tape back and get it right from the very beginning, starting at that prison in Southern California, what should have been done? You can take that, or either one. Go ahead, David.
Yeah, I think the first, this definitely was a medical error. And the reason that those residents were transferred from the correctional facility in Chino was because of the outbreak, because they had tested negative and they had high medical complexity and vulnerability. The issue is, as was determined later, is they tested negative actually 3 or 4 weeks previously. And so certainly there are a number of precautions that need to be made, moving somebody from a high-risk congregate setting to another high-risk congregate setting. And so that is being looked at a state level in terms of the root cause analysis to absolutely try to prevent that from happening again.
So if you could roll the tape back and those folks would have been tested the day before they were potentially going to get transferred and they were positive, what should have been done then?
Yeah, so this comes down to the issue of decarceration in states, right? And so if they were negative, they tested negative, they would still be in effective quarantine if they showed up at San Quentin. If they tested positive, especially as long as they being transported in buses 8-9 hours, they actually really should have been isolated from the population and kept in Chino, in the correctional facility there. But doing that in a way where you actually have appropriate space is really, really difficult. And, we look at San Quentin and they're the only area that actually houses people, that has walls on all sides is a solitary confinement area, a really terrible, awful part of the prison called the Adjustment Center. And they have 120 beds in that area, so really, really small. And so having the space to put somebody in a housing unit within the prison, but keep them separate from everybody else is absolutely vital to be able to do this correctly. The residents, when they arrived at San Quentin from Chino, they were put in one of the few housing units that has walls on most sides, but still that front area, which we saw in the picture in Bree's talk, is just all bars. And, there may be debate as to whether or not, how much COVID can pass through a cloth mask or a surgical mask, but nobody debates if it can pass through bars. And that's really what happened.
Got it. Bree, we only have a couple more minutes. You have studied correctional facilities all over the world. I know with a special focus in Northern Europe. And also, I know you've studied and looked at and consulted in other prison systems in the United States. Can you take us through, are there lessons from other places that have done this well, and the things we should have learned from that?
Do you mean COVID related or not COVID related?
Yeah, I'd say more COVID related. I mean, it sounds like the COVID related things are part of a general sensibility about some of these issues, but sort of focused more on how they handled their prisons in once COVID became a thing.
Yeah, I think some of the real successes have been places that have decarcerated. So, for example, Norway has decarcerated their population by 50% and has had no deaths in their prison population, at least as of last week. In many of the Scandinavian countries, same. North Dakota even has incarcerated, I think, 20 to 25% of their prison population, and has also had a lot of success. But I think more important, or as important as decarceration, is culture. And the prisons even where there are horrible outbreaks, the prisons where the leadership sees the people who are incarcerated as partners in the attempt to control transmission and to mitigate the horrible outcomes that can come from an outbreak, those are the prisons that are having the most success. And so the prisons where the administration is sitting down with the people who are incarcerated and asking them, how can we communicate better with you? What are your concerns? How can we get you in touch with your family, even though visitation has been suspended for 3 months? How can we get you outside of your cells? What will make you feel less unsafe? What kind of cleaning supplies do you need? Do you have access to hot water? How can we communicate that staff want to take care of people? That what's going to happen to their cell when they get transferred out? What's going to happen if they go to a quarantine cell? When will they be able to come back? Communicating with them every day to let them know when they can come back to their regular cell. These are the kind of things that are so critical, because when there's an element of trust, at least trust in the healthcare staff, more people are likely to say when they have symptoms. More people are likely to say when somebody near them has symptoms. More people are likely to follow the guidance of the healthcare staff. And when there's no trust and when there's a poor culture and it's dehumanized and undignified, then you get outcomes where staff and residents are really working at odds.
Great. Thank you. One last very quick question. This came up on the from the Q&A. Of all the things and the resources you were mentioning, you didn't mention masks. So were masks given to prisoners in San Quentin, and what is their value in this setting? Dave, do you want to take that?
Yes. When we were there in mid-June, everybody, all the residents and the staff had masks. They were cloth masks. I don't know. I think they'd had them at least for a couple of weeks, if not longer. I'm not exactly sure the date that they were distributed, but everybody there has them.
Clearly not enough, though, in that kind of setting.
Can I actually add just one other thing, which is that there's an exceptional UCSF graduate student group that has been running something called the Clean Hands Project, where they dipped into their own pockets actually to buy the supplies to mix hand sanitizer when it was hard to find, and have delivered tens of thousands of bottles of hand sanitizer that Amend and others are now funding themselves, literally mixing and pouring and labeling and driving to prisons around the state has been exceptional. So a hats off to them as well.
Well, to them and to both of you, thank you for your work in this. It's an extraordinarily troubling situation, and appreciate your contribution to try to deal with it effectively. So thank you so much. We will sign off. Hopefully we'll get a slide up that shows our appreciation to our crack team that puts these productions together. As I say, we will have this up hopefully on YouTube tonight about 7:30. So tell your friends I will tweet out the address and we'll make that available. And we'll be back next Thursday. Not quite sure what we're talking about, but there never seems to be a shortage of new things to address as this pandemic rolls on. So thank you all. Stay safe, and we'll see you next Thursday.